Hello, everyone. Thank you for joining the National Down Syndrome Society for today's webinar. Our webinar today is titled Enhancing Women's Health, Key Insights from the Primary Care Provider's Guide to Women's Health and Down Syndrome. We are thrilled to be having you with us today. My name is Lake Murray, and I am the Health and Wellness Coordinator here at NDSS. Before we dive into the content of today's webinar, I'd like to go over just a few housekeeping items to ensure that everyone has an enjoyable experience throughout today's webinar. First, if you experience any technical issues during the webinar, please use the chat function to notify our support team, and they will do their best to assist you promptly. Second, our presenter will answer questions at the end of the webinar, so we encourage you to submit your questions throughout the webinar using the Q&A feature near the bottom of your screen. We will do our best to answer as many questions as possible during the designated Q&A time during the webinar. If we are not able to answer your question, we invite you to email us the question at health@ndss.org. You can find that email in the chat as well. Lastly, this webinar is being recorded and will be shared on the NDSS YouTube channel and NDSS website within a few days. You will receive an email with the link within 1 week and links to some of the resources mentioned in today's presentation. Thank you all for your attention, and I'm going to go ahead and get started. Founded in 1979, the National Down Syndrome's mission is to empower individuals with Down syndrome and their families by driving policy change, providing resources, engaging with local communities, and shifting public perceptions. NDSS supports and advocates for the Down syndrome community by focusing on 3 areas of programming: resources and support, advocacy and policy, and community engagement. NDSS offers a 1-800 helpline and info email box that anyone can reach out to at any time. We also develop resources and information covering birth to end of life on all topics, including education, employment, health and wellness, aging, and caregiving. We encourage you to check out the resources section on our website. NDSS advocates at the federal, state, and local levels. We develop and improve laws to positively impact people with Down syndrome across the country and affirm their human rights. The legislative agenda spans the life experience of individuals with Down syndrome. NDSS also offers scholarships and grants, leads the National Buddy Walk program and Times Square video presentation, runs the Athlete Ambassador program as well as the DS Ambassador program, and hosts a variety of awareness building and fundraising events throughout the year. Our health and wellness team, which I am a part of, along with close guidance from the top medical experts in Down syndrome, is continuously creating health-related web pages and informative resources for our website and guidebooks for our community. We frequently collaborate with our policy team to participate in health-related advocacy at the state and federal levels. Our team also created and shares the 3-2-1-GO wellness program to encourage physical activity, balanced nutrition, and emotional wellness specifically for individuals with Down syndrome. I have also highlighted some other resources that are specifically for adults with Down syndrome. This includes our Aging and Down Syndrome, a health and well-being guidebook, our Alzheimer's disease and Down syndrome, a practical guidebook for caregivers, and our self-advocacy at medical appointments worksheet. Our next major upcoming event is the Adult Summit. This QR code can be used to register for this year's Adult Summit. The NDSS Adult Summit is an in-person conference covering disability-related topics from young adulthood through end of life with a whole-person comprehensive approach. It features sessions pertaining to health, research, finance, advocacy, employment, and education, as well as sessions specifically designed for individuals with intellectual and developmental disabilities aged 14 and older. This conference is a great educational opportunity for self-advocates, their family members, and professionals. This year's Adult Summit is taking place in Costa Mesa, California on November 14th through 16th, and we would love to see you there. You can go ahead and register, like I said, using the QR code, or you can use that link at the bottom of the slide. I'm excited to introduce our speaker for today's presentation, Dr. Hannah Graham of Advocate Healthcare. Dr. Graham is the primary author of one of our newest resources, the Primary Care Provider's Guide to Women's Health and Down Syndrome. We made this guide because people with Down syndrome have limited access to specialized healthcare and clinics. Additionally, women with Down syndrome receive less gynecological care than other forms of healthcare, especially when compared to women without Down syndrome. This guide aims to help primary care providers better understand the specific healthcare needs of women with Down syndrome and provide insight into the Down syndrome community. It is available as both a traditional guide and an e-learning course. This resource was made possible through collaboration with Kramer Davis Health with funding support from the WITH Foundation. The American Academy of Developmental Medicine and Dentistry and Down Syndrome Medical Interest Group USA supported the identification of reviewers and contributors. Of course, this guide would not have been possible without Dr. Graham. Dr. Graham is a physician at the Advocate Healthcare Adult Down Syndrome Center in Park Ridge, Illinois. The center serves people aged 12 and older with Down syndrome. She graduated from Loyola University Chicago Stritch School of Medicine. She completed her residency in family medicine at Advocate Aurora Lutheran General Hospital. Prior to working at the Adult Down Syndrome Center, Dr. Graham practiced general family medicine. She is currently a faculty member with the Family Medicine Residency Program at Lutheran General Hospital and the Assistant Educator Director of Family Medicine at Rosalind Franklin University Chicago Medical School. She is also a mom to a young child with Down syndrome. Thank you so much for joining us today, Dr. Graham. Please feel free to begin your presentation as soon as you are ready.
Well, thank you. Thank you for having me here today. It's an honor and a privilege to be here. And I feel like I have one of the best jobs in the world working with adolescents and adults with Down syndrome. And so I'm really excited to talk to you about some of these topics that are so important, so common, and questions that come up a lot in my clinic. So without further ado, we'll go ahead and get started. All right. So I like to start presentations just by letting you know that this presentation is intended for families, caregivers, healthcare professionals, service providers of individuals with Down syndrome. The information in this presentation is provided for educational purposes only and is not intended to serve as a substitute for medical, psychiatric, mental health, or behavioral evaluation, diagnosis, or treatment plan by a qualified professional. We recommend that you bring specific questions about an individual with Down syndrome to their medical and/or therapy providers. Some of our objectives and goals for today. We want to understand the similarities and differences in the health needs of women with Down syndrome compared to women without Down syndrome. We want to identify resources for medical providers to learn about women's health and Down syndrome. And we also want to learn some strategies to help patients with Down syndrome understand women's health topics. You heard a little bit about the support for this guide, and I think it's really interesting to drive home that the number of individuals with Down syndrome who are living in the United States has dramatically increased over the past decades. That means that there's a lot of more adults and women living longer, and so we have a lot more needs for fulfilling these needs in serving adults with Down syndrome. Despite that, only 5% of individuals with Down syndrome who are 18 and older have access to a specialized clinic. So that really means that most adults with Down syndrome receive medical care from their primary care physicians. One of the things that we want to do is help to empower those primary care physicians to continue taking wonderful care of women with Down syndrome. Another study also showed women with Down syndrome received substantially less gynecological care compared to women without Down syndrome, and they received less gynecological care compared to other forms of healthcare. So obviously there is a need here. And so thankfully NDSS has developed this guide to help serve that need and to help fill some of those gaps. All right. So this is the cover of the Primary Care Provider's Guide to Women's Health and Down Syndrome. It's available for free to download from the NDSS website. We already heard the thank you to the many contributors to help make this, that helped to make this guide possible. So the way that this guide is formatted is it's formatted in terms of cases. Now for the providers out there, We did this because this is how doctors and providers think. We think about things in terms of patients and how they might present to us in an office setting. So the topics are divided into cases, but then within each case, there's also a discussion around each individual topic so that somebody could, look up in the table of contents and jump ahead to, look up the concept that they needed to read about. So we're going to talk about some of those more common topics today. I would also like to highlight that one of the fabulous parts about this guide is that we have self-advocates who have provided perspectives throughout the guide. Their work is unequivocal and great in saying that their life with Down syndrome is wonderful. I think that their perspective in this guide adds such an important flavor and such an important identity of what it means to be a woman with Down syndrome and why this guide really matters and is important. So I'm so grateful for the self-advocates and the perspectives and the work that they did in this guide as well. Okay, before we dive into some of these topics, I think it's helpful to talk a little bit about the unique learning profile of individuals with Down syndrome. You know what they say, once you've met one person with Down syndrome, you've met one person with Down syndrome, right? Everyone is their own unique, wonderful person, right, with their own unique characteristics. So we don't talk about this in order to try and put people in a box, but rather to talk about some of the common characteristics that we do see in this patient or population. So some of those things that we commonly see are differences in hearing and vision. We see a lot of hearing and visual impairment throughout the lifespan. Delayed motor skills with hypotonia, also very common. When we think about language, I think this is an important one. We see speech and language delays, but we also see that people with Down syndrome generally have much stronger receptive language than expressive language, meaning that a person with Down syndrome generally understands a lot more than they are able to communicate back out. That's an important concept when we are thinking about how to educate people with Down syndrome and how to interact with them in the best and most meaningful way. We also think it's important to talk about, we have some verbal memory weakness in people with Down syndrome. People with Down syndrome have a harder time hearing something, processing it, and remembering it. This becomes really important when we're thinking about how we teach people with Down syndrome, that having that verbal instruction can be a little bit harder. In contrast, people with Down syndrome tend to have very strong visual learning. So they might remember something that they see for a long time. Knowing that, we can really harness those strengths and use more visual supports as opposed to verbal supports to help support a person with Down syndrome in learning a new skill or task. If we go on and think about some of the common characteristics in women with Down syndrome, we talked a little bit about that strong visual learning. It really is strong though, almost videographic in many ways, because memories that people with Down syndrome see may be experienced as if it's happening right now, re-experiencing something that happened years ago that they can remember and see again over and over. This can become significant if you think about a medical procedure, like a woman's health medical procedure that might be really traumatic. A woman with Down syndrome might be able to see it and re-experience it over and over years in the future. We also know that people with Down syndrome are very concrete thinkers, rule followers. They see things in black and white and have a harder time with abstract thinking. I think that this comes into play when we talk about the questions that we use as providers to get information from our patients. Using simple language and asking clarifying questions is really important. So a lot of medical doctors will ask their patients about their sexual history in order to determine what type of medical care is appropriate for them. The common question is to say, are you sexually active? I've had many people with Down syndrome who I've asked this question, are you sexually active? And they say, oh yes, I am. Oh, okay, tell me more about that. Well, I ride my bike on Mondays and Wednesdays, and I go for a walk on Tuesdays and Thursdays, and I do Zumba. People heard the active, right? But didn't quite understand the sexually active. So asking a more direct question like, do you know what sex is? Can help open this up and help make it a more concrete conversation, less abstract. And that can be really helpful. Another example might be talking about pain, right? Pain and time. Those are two concepts that can be kind of abstract. So a woman with Down syndrome might have a hard time answering a question like, when was your last period? Because that concept of time is abstract, and so it can be hard to answer. She might do a little bit better, understand a little bit more clearly if we ask a more concrete question like, do you have pain in your stomach when you have your period? These are some of those examples to use scripted speech to help engage a person with Down syndrome in conversation. One of the concepts that we like to talk about is called the groove. The groove is a preference for sameness that a lot of people with Down syndrome experience, liking things to be consistent and the same and predictable. Now, this can be troubling if it means that somebody is not flexible to some of the required changes that happen in our day-to-day life. But it can also be harnessed for the good because we can create a groove that's full of good habits, a groove full of healthy sleep, a groove full of daily exercise, drinking lots of water, eating our healthy food. So we can use this groove to create good and healthy habits as well. We've talked about receptive and expressive language. And then when we think about the brain, there are a lot of areas of the brain that impact memory, planning, decision-making, problem solving, social behaviors, attention, language. People with Down syndrome have a unique perspective on this, but that can also lead to impacts in their medical care. If we move on and we think a little bit about teaching strategies that work for most individuals with Down syndrome, because I've mentioned before, our friends with Down syndrome often have such strong visual memories. Visual learners often learn best with visual supports. So maybe that's a story, a visual story that they can look at. It's also relying on modeling, seeing other people performing that task. It's important to do a lot of repetition and practice. It can be helpful to practice in a variety of environments. So you might need to give someone a tour or sample the items that are used in care that you use to examine a person with Down syndrome. So maybe that means letting a woman, look at the speculum and take some time examining some of the instruments or tools that are used during an exam before she has the exam, or even the visit beforehand. When it comes to establishing that routine, people with Down syndrome, the groove is great until it isn't. But it also means that we've had people who have to have their blood pressure taken the same place, the same chair, the same order every visit, right? And that can be great. And of course, we've talked a little bit about being as concrete as possible. And we've talked also about the social support. I think that when we talk about all of these are things that we can do in multiple environments. We can teach families to do at home. We can teach educators to do at school. We can teach staff to do in group home settings. And it's something that as providers, we can always be practicing as well. Okay. Let's move on to some of the topics that are women's health specific that are going to be covered in this guide. One of the first topics that we talk about is HPV vaccine. So that would be like a Gardasil vaccine. So there are no specific recommendations about HPV vaccination for people with Down syndrome. One study did show that women with Down syndrome were less likely to receive this vaccine. This vaccine works by preventing HPV infection. HPV is a sexually transmitted virus that can cause cervical cancer in women, penile cancer in men, genital warts, and some other types of skin cancers as well. A vaccine that can prevent cancer is pretty great, and we really like that. And that's why it is generally recommended for everyone. The vaccine is generally well tolerated. So although there are no specific guidelines for people with Down syndrome, it makes sense that this vaccine should be offered to people with Down syndrome just as it is in people without Down syndrome. Moving on, we're going to talk about menstruation periods. So menarche is the medical term meaning the first period that a young woman experiences. So the average age of menarche is around 12 for all women. When it was studied in Down syndrome, it appears to be pretty similar to women with Down syndrome. Some studies suggest that women with Down syndrome might experience periods a little bit younger, but that hasn't been shown in every study. Some of the studies that found that we're wondering if it might be related to just higher body weights, and maybe that's why women with Down syndrome sometimes experience periods at a slightly younger age. We don't really know for sure. Most of the studies seem to show that women with Down syndrome start getting periods at about the same age as women without Down syndrome. One thing that comes up a lot when talking about periods is period hygiene. This can feel like a really overwhelming task for some young women with Down syndrome and some older women with Down syndrome. I think it's helpful to know that with support, women with Down syndrome can be independent or partially independent with their period hygiene. There can be a lot of skills that we can teach women about knowing when to change her pad, how to change her pad. Sometimes it involves practicing ahead of time. We find that since the fine motor manipulation can be challenging for some women with Down syndrome, sometimes using a pad without wings makes things a little bit easier. There are also a variety of new products on the market, like period absorbent underwear, that have been particularly a big hit for some women with Down syndrome. Period suppression is the concept of giving a birth control pill so that a woman does not get a period. And it might mean that a woman doesn't take that blank week of the birth control pill, so she just continuously takes the birth control pill and does not get a period. We're going to talk about that a little bit later on in this talk, but I think this is a good place to say that period suppression does not have to be the first line of care for when a woman is struggling with her period hygiene. Sometimes if period hygiene is really challenging, people just reach for period suppression because that kind of fixes the problem by getting rid of periods. There might be cases where that's the right thing to do, but it's helpful to know that with the right support, so many women can be partially or fully independent with their period hygiene. Next up, we have some examples of the visual supports that might be used to help support women with Down syndrome. So these are linked in the Women's Health Guide as well, and some of them are printed in the guide too. But our resource library at the Advocate Adult Down Syndrome Center has a lot of resources on there. We have it broken down for resources that are for providers, resources that are for family or caregivers, and also resources that are for people with Down syndrome. Dr. Katie Frank at our center has helped to make a lot of these visual supports that can support women with Down syndrome and are available for you all to look up and use as needed. She has a lot of great stuff on there about menstruation and about period hygiene. So here is an example of menstruation. In the next slide, we have one looking at period hygiene, and this is about a story about when to change my menstrual hygiene product. And then the next slide has, these are a couple of visuals put together, but we have developed some visual supports helping a woman learn how to change her tampon, how to change her pad, how to change her period panties. All of these with visual supports so that the goal is to help that woman with Down syndrome be independent in her hygiene. All right. So we'll keep going to heavy or painful periods. So the incidence or frequency of heavy or painful periods in women with Down syndrome is not reported. But the workup and testing that a provider would do is the same as it would be for a woman with Down syndrome or without Down syndrome. The I think one thing that's important to keep in mind is that it can be hard for a lot of our women with Down syndrome to express that they're having pain. I hear so often, my loved one with Down syndrome has a really high pain tolerance. And it can be really hard for our friends with Down syndrome to tell us that they're having pain. So sometimes that pain or discomfort presents itself in a different way. Irritability is actually a very common presentation of maybe heavy or painful periods. Maybe it's a new behavior that happens on kind of a cyclical monthly basis and is related to the period. As they say, all behaviors are a form of communication. So we can always look for those new behaviors and see if they correlate with the period, and if potentially that change in behavior is maybe related to a painful or heavy period. When we think about the treatment for heavy or painful periods, NSAIDs, which are the non-steroidal anti-inflammatory agents, are considered the first line. These would be medicines like ibuprofen, naproxen, lots of over-the-counter formulations like that. Not Tylenol. Tylenol, acetaminophen is a different category, but ibuprofen, naproxen, medicines like that are NSAIDs. Sometimes we have women start NSAIDs around the time when they're expected to start their period. And that way she already kind of has those NSAIDs going when the periods start, and that can help reduce the pain or before it really gets ramped up and gets going hard. The other first line treatment of periods, painful periods or heavy periods, would be birth control pills. We're going to talk a little bit more about birth control in a little bit here, but for many women with Down syndrome, it might make more sense to start with NSAIDs. You do need to monitor for side effects from NSAIDs and kind of do this under the supervision of a doctor to make sure that there's no concerns about kidney function or anything like that. There can be some GI side effects from NSAIDs, so it can be helpful to take it maybe with food, so you're not taking it on an empty stomach. But these are typically some of the first line approaches to heavy or painful periods. Okay. Next up, we're going to talk about premenstrual syndrome and premenstrual dysphoric disorder, PMS. It gets talked about a lot in our culture and in our society. It gets thrown around all the time. There are true diagnostic criteria to make a diagnosis of PMS. PMDD is a more severe form of PMS. It just has more physical symptoms associated with it. These disorders are very common. This number is talking about in general, not specific to women with Down syndrome, but up to 12% of women experience these disorders. There are no studies that compare the prevalence of these conditions in women with Down syndrome, but they appear to be as common in women with Down syndrome as in women without. When we think about treatment, the two kind of first line treatments that people talk about for treating PMS and PMDD are birth control and the selective serotonin reuptake inhibitors, SSRIs. So that would be medications like sertraline, escitalopram, fluoxetine. Those are medicines like Zoloft, Lexapro, Prozac, medications like that. Birth control is coming, so birth control pills are coming. There might be some special considerations before starting birth control pills. We'll get to that. When we think about using the SSRIs to treat PMS and PMDD, there are two generally accepted approaches to this. Some people say to take the SSRIs only during the luteal phase, which is the time in between ovulation and the period starting. And some people say to take the SSRIs continuously. Generally, it is much easier for women with Down syndrome to take the SSRIs continuously as opposed to only for 2 weeks at a time and timing it with a period. It's nice to know that SSRIs do have FDA approval for the treatment of PMS and PMDD. All right, we'll go on to the next slide. So, birth control. There are so many different methods of birth control. When we think about the non-medication options, these non-medication options are often not the best solution for most women with Down syndrome. These would include things like barrier methods, which are condoms, These can require a lot of manual dexterity that might be challenging for some women with Down syndrome. Non-medication options also include things like natural family planning, which can require a lot of close self-monitoring, and that might be challenging for some women with Down syndrome. Besides these non-medication options, there are, of course, the combined oral contraceptive pills. These are the combination of estrogen and progesterone at low doses to help prevent pregnancy. Like we talked about earlier, they can make periods lighter. They can help treat PMS and PMDD. They have a lot of roles. Now, some of the side effects of these medications is that they can increase blood pressure. Thankfully, it seems that a lot of women with Down syndrome, a lot of individuals with Down syndrome tend to have lower blood pressures. So maybe that's not as big of a concern for many women with Down syndrome if their blood pressure is affected by the birth control pills. But they also are, the combined oral contraceptives are also associated with an increased risk of blood clot. This becomes important because we don't actually know in women with Down syndrome if they are at a higher risk of blood clot already. So if we look at adults with Down syndrome, there are no studies looking at the rates of blood clots. I am aware of a study in children with Down syndrome that showed that children with Down syndrome were at higher risk of blood clots. So that's kind of interesting. We also know that autoimmune diseases are associated with an increased risk of blood clots in general, and people with Down syndrome have higher rates of autoimmune disease. So all of this kind of adds up to suggest that maybe women with Down syndrome at their baseline have an increased risk of blood clot, but there's no data to tell us how big that risk is. There's no measurement yet to say how significant it is. But I think it's important to keep in mind when we're thinking about birth control. Besides those combined oral contraceptives, there are also the progesterone-only pills. So this is a birth control pill, but instead of containing estrogen and progesterone, it only contains the progesterone. We also have our injectable progesterones, like the depot shots. These are long-acting birth control pills you do with a shot every 3 months. They are effective for birth control. They are associated with some weight gain, which might be a concern for some of our women with Down syndrome. There's also a question that they possibly are associated with a decrease in bone mineral density, although that is not quite as clear, and it does appear that it resolves upon stopping the depot injections. So maybe still some questions around that. Some women with Down syndrome are interested in like a long-acting reversible form of contraception. So that might be like an implantable device, like a Nexplanon that is placed inside the inner part of a woman's arm. These are very effective forms of birth control. They usually require an in-office procedure, so it might depend a little bit on a woman's tolerance for these types of procedures. There are also things like an IUD, an intrauterine device. There are different types of IUDs. Some of them are progesterone containing, and some of them contain no hormones at all. The progesterone-only IUDs have progesterone that is not absorbed into the whole body, but just at the local level of the uterus. They are very effective forms of birth control. They can make periods lighter, maybe a little bit of spotting, but sometimes periods will stop altogether. The non-hormonal IUDs would be things like a Paragard, a copper IUD. These types of IUDs work because copper is spermicidal, so copper kills sperm. So it's an effective form of birth control. But the copper IUD can also make periods a little bit heavier and make period cramps more painful. There have been women with Down syndrome who have had IUDs placed, but IUDs are placed in an in-office pelvic exam procedure, and this procedure might be really difficult for some women with Down syndrome to tolerate. Sometimes women with Down syndrome have to have these placed under general anesthesia. I think it's also important when considering an IUD to think about a woman's ability to communicate any discomfort or trouble she might be having with the IUD. Probably want to make sure that she would be able to communicate that to us before implanting an IUD. When we got the other considerations to think about with birth control. One is migraines. So if any woman has a history of a migraine with an aura, so an aura is like a shimmery light, right? It's like something that you kind of see when your migraine is starting. It can be difficult to explain. If you have a migraine with aura, generally birth control pills are contraindicated, not recommended, because they're not considered safe. They can increase risk of stroke. In women with Down syndrome who have a history of migraine, it can be very challenging for some of those women to describe accurately whether or not they are having an aura. So if we're not completely sure that that woman with Down syndrome is having a migraine with no aura, it might be best to avoid those estrogen-containing birth control pills. Another important consideration for this population is congenital heart disease. Of course, up to 50% of babies with Down syndrome are born with congenital heart disease. When we think about congenital heart disease, it's important to remember that the Global Care for Adults with Down Syndrome guidelines recommends monitoring by a cardiologist for adults who have had congenital heart disease. Also good to know that the progesterone-only pills that we talked about are category 1, which means they have no restrictions, for people who have valvular heart disease. So for some women, that might be a better option. Oftentimes, it can be helpful to consult with a cardiologist prior to initiating oral birth control pills. All right, we're going to move on to talk about polycystic ovarian syndrome. So one study found that PCOS was less common in women with Down syndrome. However, it is very common in women without Down syndrome, and it is still common in women with Down syndrome. The workup for a woman with and without Down syndrome should be the same. Checking the thyroid is a standard part of that workup, but it's especially important for women with Down syndrome because we know that thyroid disorders are much more common in people with Down syndrome. The PCOS is diagnosed with the Rotterdam criteria. So it's when a woman meets 2 out of the 3 criteria for dysregulated ovulation, which would be some really irregular periods, androgenic hair growth, really bad acne. And then the 3rd criteria would be visualizing cysts on the ovaries. Visualizing cysts on the ovaries is usually done with a transvaginal ultrasound. So that's not an abdominal ultrasound on top of the stomach, but transvaginal is just as that sounds. It's basically a vaginal exam doing the ultrasound. So that's the best way to get a good look at the ovaries and determine if there are any cysts. A transvaginal ultrasound can be very challenging for a lot of women with Down syndrome to tolerate. Sometimes, if that ultrasound information is really needed, an abdominal ultrasound might be able to supply enough information and allow a woman not to need to undergo a transvaginal ultrasound. When we think about the treatment goals for PCOS, classically, the treatment depends upon fertility goals. So if a woman does not want to become pregnant, typically you treat her PCOS with oral birth control pills, regulate her hormones, kind of get everything back in check. If a woman wants to become pregnant, classically you treat with metformin, which is a diabetes medication actually, but it helps to kind of re-regulate and get periods a little bit more consistent and ovulation more consistent. I think both of those options are available and can be considered for a woman with Down syndrome. This is where I think it's so important to have a shared decision-making approach where the woman with Down syndrome, her caregivers, and her providers can have a conversation about what are the goals for her care, what is the data about her condition, and what would she like to do going forward to make sure that her medical care aligns with her goals for her life, right? I'm going to talk about shared decision-making a lot in some of the coming topics, but maybe this is one of the first places that I'm bringing it up. This idea that there's lots of different treatment options. And so it's working as a team with the woman with Down syndrome at the center of that team, her caregivers and her medical providers, all on her side. Okay.
Dr. Graham, you have
Yes.
about 10 minutes left.
Okay, thank you. Oh man, I gotta pick up my pace. We got this, guys. We can do it. Okay, so pelvic exams. This is a big one, right? Because so many times, I think a pelvic exam can be very traumatic for a woman with Down syndrome. Not always. I don't want to ever put everyone in the same box, but generally it can be very challenging. When a pelvic exam is needed, there are some modifications that can help. Sometimes we avoid using those stirrups, using more of like a butterfly pose. You can do a modified bimanual exam and avoid using a speculum. During the bimanual exam, you don't use a speculum, but use the gloved fingers to guide a brush or a swab and collect the needed cells. Um, a woman with Down syndrome might be able to tolerate this exam a little bit easier if she's had been able to review the exam ahead of time. We talked before about looking at the equipment at a previous visit, right? Looking at a speculum. We also have some pelvic exam social stories available so that a woman knows what to expect going into the exam. It can also help if she has a trusted female caregiver or family member with her during the exam. And regardless of the physician's gender, it's recommended to have another person in the room to assist with the exam. Okay, next up, cancer screenings. I love this part because this is where I get to tell you some great news. Solid tumor cancers are very rare in women and people with Down syndrome. Hooray! It's great news and we'll take it. If we look at cervical cancer specifically, if we looked at a study of cancer mortality in people with Down syndrome, found no mortality due to cervical cancer. So that's really awesome. There are no formal cervical cancer screening guidelines that are specific to women with Down syndrome. Some authors have proposed that for women with intellectual disabilities, it might make sense to tailor the screening to fit a woman's risk of cervical cancer. We talked about how most cervical cancer is caused by HPV. So in a woman who's not sexually active, she would not be exposed to HPV. Her cervical cancer risk would be so low. In our women with Down syndrome, it's important to remember that there are some women who choose to become sexually active. But we also know that all of our friends with intellectual disability are at increased risk of sexual abuse. So that means that we might not know if they've been exposed to HPV. So it's always something we have to keep in mind. It's important for providers to have that risk-benefit discussion about the benefits of screening for cervical cancer, which is rare, versus the risks of the exam. Related, breast cancer screening. Breast cancer is super rare in people with Down syndrome. Awesome. A statistical computer model was published showing that it took nearly 17,000 mammograms in women with Down syndrome to save one life from breast cancer death. I guess, again, this is statistical modeling, but if you compare that to 2,200 mammograms in women without Down syndrome, there are no formal recommendations for breast cancer screening in women with Down syndrome. It's important to note that is also no data that is looking at what a woman with Down syndrome's risk of breast cancer is if she has a family history of breast cancer. There is just no data. So I think this is also a point where we have to have that conversation about the risks and the benefits. Some women tolerate mammograms, some women don't. There's a risk of false positives with mammograms. So we have to consider all of these things when making these tailored decisions for women with Down syndrome. But I think the great news is that in general, breast cancer is very rare in women with Down syndrome. All right, next we're going to talk about sexuality. So some women with Down syndrome choose to become sexually active. It's important then to be thinking about sexually transmitted infections and to be educating them for preventing sexually transmitted infections, which have been found to be statistically less common in people with Down syndrome. But it's very important to always remember that sexual exploitation is higher in women with Down syndrome. There are higher rates of sexual abuse. Some of the ways that we can help to prevent that are with education for the women with Down syndrome. If we think about sexuality and education, this slide here is looking at some of the unpublished data from a study done by Frank and Sandman, but it talks about how 73% of parents reported that children received sexual education in the classroom, and 85% of parents initiated home-based sexuality education, but the availability of adapted materials both at home and in the classroom is very limited. Parents understand the importance of sexual education, but often lack the comfort and confidence to talk about it. I think it's also important to know that a lot of times students with Down syndrome are pulled and not included in this part of education. And also the information is often one and done, right? They talk about it and we never talk about it again, which can be problematic because people need to hear about it over and over to really have that drive home and really stick. Related to these ideas of sex education, we talk a lot about consent at our clinic. A yes is freely given. It's where you give permission. You can give permission, but you can also change your mind and take it away. There are different components of consent. There's information. Do you understand? There might be, limited opportunities for adapted education. So making sure that we've really taken some time to kind of talk about this in a way that makes sense for our women with Down syndrome. Thinking about how we ask questions, right? Are you sexually active? Do you know what sex is? And then there's also voluntariness. This is another part of consent about who gets to touch somebody's body. We can model this in how we interact with people with Down syndrome. It means asking permission before a physical exam. May I listen to your heart? And we pause and we wait for that permission before we start. It means as a parent, we knock before we go in the room and we wait for permission to enter. We ask for permission before we assist with self-care. May I help you with your hair? So these are all ways that we can model that voluntariness and that consent. These are some of the visual supports that we have about consent on our website. And then next, we're going to talk about pregnancy. So fertility rates for women with Down syndrome are reduced, but there have been many documented cases of women with Down syndrome giving birth. I also would like to say that men with Down syndrome maybe have reduced fertility, but men with Down syndrome are also capable of fathering a child. So just because there is a man and a woman who both have Down syndrome or in a relationship and choose to become sexually active, it is possible for them to conceive a child. Less than half of children born to a woman with Down syndrome have Down syndrome themselves. So for all of you geneticists out there, that's kind of interesting because you would expect it to be a 50% chance, less than 50%. That's probably because those eggs that contain the extra chromosome have less of a chance of surviving or being fertilized, or of that fertilized egg with the extra chromosome being able to implant and become a successful pregnancy, questions like that, but I think it's interesting. Women with mosaic Down syndrome are more likely to be able to become pregnant. Sterilization sometimes comes up. I think that's beyond the scope of this guide today, except to say that there is an egregious history of sterilizing women with intellectual disabilities without their consent in the 20th century. So the response to that has been that there are now a lot of legal and ethical nuances around sterilization. And if this topic comes up, it's probably best to involve your local ethics board, because there is a lot of variation between state and countries' laws regarding sterilization. Next up is menopause. So fun. The estimated age of menopause in women with Down syndrome is between 44 and 46. It's 51 for women without Down syndrome in North America, so menopause is happening earlier. We do see that many of the same symptoms for women with and without Down syndrome. Hot flashes, in particular, is something that can be difficult for women with Down syndrome to describe. Sometimes it's family members or caregivers who are really observing those hot flashes. The treatment of menopausal symptoms in women with Down syndrome is often very similar to women without Down syndrome. Again, I'd like to say that hormone replacement therapy, which might be an appropriate treatment option for some women, has not been studied in women with Down syndrome. So just a lack of data, we don't know. Sometimes you hear about there's a research question out there about women with Down syndrome and they have a short interval between the age that they are diagnosed or the age that they go through menopause and the age that they're diagnosed with Alzheimer's disease. It's an interesting research question that needs more study. We don't know enough about it to make any treatment guidelines or recommendations or changes in how we are taking care of women yet. But I'd like to bring that up so that if more information comes out, you'll have at least heard that this is an area of interest for further research. We have some visual supports about menopause. These are about what menopause is. The next slide talks about some of the common symptoms like hot flashes, emotions, sleep, weight. Okay, next up is our last health topic, osteoporosis. So osteoporosis is reported to be more common in women with Down syndrome or in people with Down syndrome, and it's reported pretty broadly. You make the diagnosis of osteoporosis using a bone scan called a DEXA scan that's looking at the density of the bones. There's a growing body of evidence that DEXA scans may be inaccurate in their reporting of bone density in women with Down syndrome. So that's really interesting. There are also very few studies that report fracture risk in women with Down syndrome. So while osteoporosis is reported to be more common, we're not sure that the scans we use to diagnose osteoporosis are accurate. And we also don't know that women with Down syndrome are experiencing more fractures. So actually more complicated than it seems. There is also no studies looking at the medications that we use to treat osteoporosis in people with Down syndrome. We also know that people with Down syndrome might have differences in their bone formation pathways. So some of those medications, which work at the bone formation pathway level, might work differently in people with Down syndrome. So lots of questions. I think we have a lot we can still learn. Ultimately, the Journal of American Medicine's article on the care for adults with Down syndrome says there is insufficient evidence to recommend for or against applying established osteoporosis screening guidelines. So there's insufficient evidence to recommend DEXA scans or to talk about how to apply FRAX scores or some of those other tools that doctors use to make recommendations around osteoporosis. So again, a shared decision-making approach can become very helpful. Okay, I flew through the last bit there. Some final thoughts. A self-advocate said this to me once, and I liked it. She said, life with Down syndrome is great. Yes, it is. While there are some differences, there are also a lot of similarities in the healthcare of women with Down syndrome. The lack of specialty clinics for women with Down syndrome means that the healthcare for women with Down syndrome is in the hands of primary care providers. Healthcare providers generally lack information that's providing accurate and specific healthcare for women with Down syndrome. I want to thank all of the healthcare providers who are listening today for the amazing care that you are providing for women with Down syndrome, because 95% of women with Down syndrome are getting their care from you. Thank you for helping to care for this incredible patient population. We hope that this resource will help you as you continue to make the world a better place. So I think we have some references. And then do we have time for questions?
Yes, we definitely have a few minutes for questions. I'd just like to start off by thanking you again, Dr. Graham. I know we were all appreciative of that very valuable information you just shared with us. Like I said, we have time for some questions, so we'll go ahead and move into our Q&A. So quite a few questions came in about recommended guidelines with some things you went over. So maybe we could start off with a couple questions that came in about if there's a recommended age for a first pelvic exam, and also similarly if there are any recommendations with how frequently women with Down syndrome should be getting gynecological exams.
Sure. So the American College of Gynecologists recommends cervical cancer screening with a pap smear starting at age 21 through the age of 65. And so there are no specific guidelines about when a woman or if a woman with Down syndrome should do cervical cancer screening or when she should start. So that ACOG, American College of Gynecology guideline, just applies generally to the entire population. And depending on the type of pap smear that's done and the specific age of the woman, the ACOG guidelines say to do a pap smear for cervical cancer screening every 3 to 5 years. So there is no specific guideline for women with Down syndrome, but we do know that women with Down syndrome have lower rates of cervical cancer. Some authors have proposed adjusting the screening guidelines based off of the risk that each woman is experiencing for cervical cancer. That would really rely on a shared decision-making approach between a woman and her caregivers and her provider. Some authors proposed starting cervical cancer screening for women with intellectual disabilities at age 21, and then determining the follow-up or the further screening depending on her cervical cancer risk. So the American College of Gynecology recommendation generally applies to the entire population, and there's no specific guideline for people with Down syndrome. And we just have to take all of this knowledge that we are getting, and hopefully we'll continue to advance in this field.
Great, thank you. Along those lines, we had a question come in. We know you shared a bunch of great information about how to make pelvic exams a little bit easier for women with Down syndrome, but if there's someone who is unable to tolerate a pelvic exam at all, do you know of any alternatives?
We talked a little bit about like some of the ways that we can help prepare the woman with Down syndrome for that pelvic exam with social stories. And then there are other resources for providers, and they're referenced in the guide as well, that might help the provider make some modifications for the exam to make it more manageable for the woman. There are rare cases where women with Down syndrome who really need that pelvic exam have to undergo that exam under anesthesia. I'm always a fan where if somebody has to undergo anesthesia for some sort of exam, maybe we can bundle it, right? We can get the ears clean and the teeth clean to do the pelvic exam all at the same time. But there are resources both for the woman and the caregiver and for the provider. And then occasionally there are situations where an exam under anesthesia is the best or only option.
Great. We also had a question come through on endometriosis, and if there's any research or if you know of anything about the prevalence about endometriosis among women with Down syndrome compared to the general population.
Yeah, I think that that's an interesting question. I'm not really aware of any information about the prevalence in women with Down syndrome. I don't think we really know. So I think it's an interesting question, and I wish I had a better answer other than to say I'm not aware of anything that tells us how often it's happening for women with Down syndrome. I think if we suspect endometriosis, I think some of the, the treatments that you might consider for endometriosis sometimes use birth control pills and things like that. We could apply some of the same concepts that we talked about earlier, but yeah, unfortunately, it's one of those areas where we're really lacking data. And I thank you for the question though, because I hope we can get those answers someday.
Yeah, great. Another question we had come through was related to dementia and Alzheimer's disease. We know that people with Down syndrome tend to have higher prevalence of Alzheimer's disease. Are there any risk factors related to this specifically for women with Down syndrome?
Well, we know that all people with Down syndrome are at increased risk for Alzheimer's disease. Down syndrome is the #1 genetic cause of Alzheimer's disease in the world, actually. And if people with Down syndrome live into their 60s, greater than 90% will develop Alzheimer's disease. So we do have a lot of work to do to figure out how to treat and help prevent this in our patients with Down syndrome. When we think about women with Down syndrome and their risk for Alzheimer's disease, I think that the risk is just so high for everyone with Down syndrome, man or woman. So there is a lot of work to do. I think I talked about this idea about the interval between the diagnosis of menopause and the onset of Alzheimer's being shorter in women with Down syndrome than in women without Down syndrome. So I think there's some interesting questions there about the role that estrogen or hormones might be playing in preventing Alzheimer's disease. I don't want to jump to any conclusions. It's just interesting. We have a lot of questions, and frankly, we don't have enough answers yet. So at this point, that's what we know, but I have a dream of a world where we know more about this and I can give you a better answer.
Yeah, great. Thank you so much, Dr. Graham. I know we had so many other questions come through today, but unfortunately, that is all we have time for today. Like I said earlier, if we did not get to your questions, feel free to email us at health@ndss.org. Um, you can go to the next slide. So we hope you learned a lot today during today's webinar. Immediately following this webinar, a short survey will appear on your screen. We invite you to share your feedback and ideas you have for future webinars. Your feedback is important to us, and we really want to improve these webinars for you. So before we close, we got quite a few questions as well about some topics that our NDSS resources address. So I would like to take a moment to not only thank Dr. Graham one more time for her expertise and insight with us today, but also highlight some more resources we have. Like I mentioned, we have the Primary Care Provider's Guide to Women Health and Down Syndrome, but on our page, we also have a few one-pagers. These one-pagers are titled The 3Ps, the Gynecological Exam, and Feminine Hygiene. Additionally, Advocate Healthcare has many resources, so please check out those resources from the Advocate Healthcare Adult Down Syndrome Center Resource Library. Dr. Graham has also provided us some additional resources to share to highlight, to share on sexuality. So one more time, if you have any further questions or comments, feel free to reach out to us at health@ndss.org. And thank you all for attending today.